Hello, everyone. Let's go ahead and get started. Dr. Zaveri, will you introduce us all?
Yeah, absolutely. Good evening, everybody. My name is Aditi Zaveri, and I'm really happy to help kick off this quarter's Pediatric Assembly Town Hall. Today, we'll be talking about the evolving landscape of home respiratory equipment. We'll start off with our presenters that include myself from UPMC, the Children's Hospital of Pittsburgh, and Dr. Jane Taylor, also from UPMC, the Children's Hospital of Pittsburgh. We've put together an expert group of panelists for you all today. So it brings me great pleasure to introduce Dr. Amit Agarwal from Arkansas Children's Hospital, Dr. Ann Coates from Barbara Bush Children's Hospital, Dr. Jacob Caslow from Vanderbilt University, Monroe Carroll Jr. Children's Hospital, Dr. Richard Kravitz from the University of Virginia Health Children's, Dr. Oren Kupfer from Children's Hospital of Colorado, Dr. Hiren Mazumdar from UPMC, Children's Hospital of Pittsburgh, Michelle Wright, one of our RTs from UPMC, Children's Hospital of Pittsburgh, as well as Brian Yoho, another one of our wonderful RTs from the Children's Hospital of Pittsburgh. Moderating our session today, we have Dr. Jane Taylor and Dr. Ann Coates, as well as Dr. Adrian O'Hagan from the University of Louisville, Norton Children's Hospital, as well as Dr. Christina Galletto from UPMC, the Children's Hospital of Pittsburgh. So without much ado, I think let's kick it off. Dr. Taylor, do you mind pulling up the slides?
Absolutely. Let's get started. Okay. So we are going to start by talking about some of the newer home respiratory care equipment that is in use for our patients. And we are first going to talk about some of the new home ventilators that are on the market. And we will then start talking about some of the new mechanical insufflation, exsufflation machines or cough assists that are also out there. So first off, home positive airway pressure devices. What are we using? And it's first important to discuss some of the key differences because a lot of our students and trainees talk about BiPAP machines and home ventilators interchangeably, and they're really not. The BiPAP machines are slower to adjust. They have to have individuals that are 30 kilograms or more to accurately have the flows needed to trigger. There are less bells and whistles, and there's no internal battery backup. So if we lose power and the patients are on a BiPAP machine, it's not going to kick in and keep supporting them. It's also only been FDA approved for non-invasive. So this is not something that you can use with a trach patient. Now, the home ventilators can quickly adjust, even breath by breath, and can be used on much smaller kiddos. So the Trilogy Evo is down to 2.5 kilograms. Most of the others we're going to talk about is about 5 kilograms on up. They have a lot more alarms, and they also have internal battery life for 8 hours, and then external batteries can even increase that. So there's a much bigger safety net for these pieces of equipment. They have better algorithms where you can download data and make adjustments, and it's been FDA approved for both non-invasive and invasive ventilation with a tracheostomy. So with that said, the top row are the BiPAP devices. And as you can see, half of the device is actually the water chambers for the heated humidification. These things are small, they are portable, they are easy to take place to place, and there are lots of different types that are currently on the market. Now, as we all know, Philips Respironics is starting to pull out of the respiratory market. So the Philips Dream Stations are being phased out, but the rest of them, all of us have many patients that are on these devices. Now, for the home mechanical ventilators, this is where we recently, with COVID-19 and then Philips pulling out of the respiratory care market, have actually had the opportunity to start exploring a lot of different types of ventilator units. And one size does not fit all, and they all have some pros and cons associated with them. So that's why we wanted to today talk about some of the different options and what would be best for different patient types. So with that, we still have some of the Philips Respironics, mostly the Trilogy Evo. We have the Ventec series that we'll talk about, ResMed Astral series, also the Brios Vivo, especially for some of the older working professionals, they prefer that. And then the MoveAir Luisa is about to be FDA approved for adults and has requested pediatric approval as well, and are trying to expedite that. And the LTV is still around. So let's first start talking about the Trilogy Evo. And this is something that we use predominantly at UPMC Children's Hospital of Pittsburgh, although now we are going to be phasing into other types of vents. But we liked it because it is fairly small. It's only 11 pounds. It had good combined battery life of 15 hours. It was easy to use, and you could use it invasively and non-invasively, and was down to 2.5 kilograms. So this is no longer being made, but replacement parts are until January of 2029. But after that, they are not even going to make the replacement parts. So this will be unavailable in the future. So we now have the Ventec series. And what's important to know is that it started off with the Voxen, which has a lot of extra added features. It then, they also make two others, the V Home and the V Pro, because they're faster to make, but doesn't have all the extra bells and whistles. It's just the home ventilator unit. So the Voxen, when it came into being, is a little heavier. It's 17 pounds, but it still has some pretty good battery life, internal, external, 9 hours. This is where you need to be aware that can be variable, because this is one of the ventilator units that actually has some extra features. And it can have an O2 concentrator up to 6 liters. It can have a built-in cough assist, although it doesn't have the oscillatory capabilities or the PEEP on pause, but it is a standard cough assist machine. It has suction and a nebulizer. And where I have had great success with patients are the middle and high schoolers who go to school with some of their home health aides. And it's very hard for them to take lots of different pieces of equipment with them. So this has worked extremely well for those types of patients that are trying to get room to room and not interrupt their educational experience by having to carry all this extra baggage with them. But just be very aware that when you order the Ventec, if you don't specify Voxen, you could get the V Home or the V Pro, which is also an excellent ventilator. It's in the same type of case, so it looks the same. It just does not have the O2 concentrator, cough assist, suction, and nebulizer inside. So the ResMed Astral, I know that this is the go-to vent for Colorado and UVA, and this is what we are going to be transitioning to at UPMC Children's Hospital of Pittsburgh as well. It weighs 7 pounds. It has excellent battery life, 16 combined hours. It has invasive, non-invasive capabilities, and the full pressure and volume modes. So it also is an excellent vent. Now there still is the Viair LTV, and I think this is going to age me because this is what was available when I came out of fellowship. This was the only home ventilator that was out on the market at that time. It does weigh a little more. It's 13 pounds. Combined battery life of about 9 hours. This thing is a workhorse. It does not break down, and patients swear by it. So I still have some patients that are on this LTV. And Viair, when they found out that Philips Respironics was pulling out of the market, started working on an LTV2. And we'll talk about that in a little bit as well, but there's going to be a newer version that's coming out fairly quickly. And this has always been a very reliable company as well. There's the Breus Vivo 45 LS. It is only 5.3 pounds. It has fairly good combined battery life, 9 hours. And this is one where I don't have any patients on it myself, but on some of the national committees and meetings that I go to, some of our young advocacy group that I know uses this one because it is so small. It's very easy. It's portable. So they are young professionals and they need to be able to grab their stuff and get up and go. So they have said that this has been extremely helpful for them. Now here's the Movair Luisa, and I have not had any experience with this, but some of our adult sleep providers here at UPMC actually do have a few patients on this ventilator, and they report that they've had great success with it. It is about 8 pounds. Battery life is 18 hours, and this actually has high flow therapy on it. And what is nice is that it also has the ability to kind of chart breath by breath changes. So you can make adjustments in clinic and see what you're doing on the actual screen. So our adult sleep docs have actually liked this. And this is the one that is just about to get FDA approval for adults, and they have expedited FDA approval for pediatric patients once they found out that Philips Respironics was pulling out of the respiratory care market. So be aware of this one as well. Now, a lot of people ask about ventilator dimensions, and the reason is because as patients start to switch from one vent to another, there's a lot of equipment that needs to go on their wheelchairs, and to know what to order, the DME companies need to know the dimensions of the vents, so it's right here. So you guys that are listening can look back and see what they are. We also recently put together a chapter that had some tables, and we'll include the link in the chat. And this just goes over the different types of ventilators that are currently available in North America, so Canada, the US, and Mexico in 2023. And it compares the company, the name of the ventilator, the actual weight requirements, the ventilator weight itself, the internal and external batteries, mode supported, and other features. And Dr. Kupfer was kind enough to go through and make an updated comparison table for us for today's talk. And that also is including some of the new information on the LTV2 and the Luisa ventilator. So this again is something that is going to be put up on the ATS town hall site so you guys can reference it. So now that we've talked about some of the newer home ventilators, let's also mention some of the new insufflation exsufflation devices, or the cough assists. And there are three main ones that most of us have the ability to use in the home setting for our patients. The first, of course, is Philips Respironics T70 Cough Assist. This is one that, as it starts to break over time, will be phased out. They're not making new units, and will be replaced by the ABM Byways cough system and the Hillrom Sinclair cough system. And I have patients on all three, and they all like their cough assist machines. What I like to quickly review is to show people that with the cough assist, you can see with these green breaths, these are without the support, there's not as much flow. And when we turn on the actual cough assist pressures, that helps increase the flow significantly, which ultimately helps remove the mucus. And then always end on that post-therapy breath, so with a push in. And this, of course, is on the Philips Respironics system because they did the initial studies, but it's the same type of mechanism for the other two as well. Same flow dynamics. Now, the oscillatory settings, which are on all three, what they do is instead of having a consistent push in with the pressure, so whoosh, they allow you to adjust the amplitude and the frequency. So you have some vibrations. This helps increase shear forces. That loosens the mucus and helps you then pull it up and out with the insufflation exsufflation maneuvers. And what is nice is that the two newer machines, so the Byways and the Sinclair, actually have PEEP on pause. And what that is some extra pressure that remains, and it doesn't go all the way down to 0. So you can set 4 to 6 for young kids and all the way up to 8 to 10 for older kids. And that just keeps the upper airways open while they're trying to cough the mucus up and out and prevents some malacia. So again, here are some recent kind of recommended ways to start cough assist in the pediatric population. And again, there's a link sent in our chat so you can get to the paper that way. And just goes over different things to think about when you're setting the pause times, the oscillations, and the positive airway pressure. So with that, what we're going to do is start to take questions. And what we will first start off with is have our panelists introduce themselves, give a little bit of information on what they're using locally, and then we will jump into questions and have the panelists kind of talk back and forth.
So I'm Amit Agarwal. I'm from Arkansas Children's Hospital, pediatric pulmonary, and so we have been using LTVs as Jane mentioned, but since Trilogy 200 departed, but we still have some of those we are using. We got EV300, and that's the hospital version of Trilogy Evo. And also, we were the first, among the first hospitals to use Vivo 65 model that we have some experience with since last 5-6 years. And also, our hospital is going to be buying the vPro or ventilator system. So we have had a couple patients that we have tried. The only thing that I would say, we have had good success with using the AVAPs or the volume targeted mode in BPD population, as well as in non-invasive way in neuromuscular disease. And we are working with Dr. Jake Caslow and about our experience, both our hospitals' experience with using volume targeted mode in BPD population, and that we are seeing more and more other ventilators have availability of. I will stop here and have other people chime in.
And Dr. Coates, you're next. Well, it sounds like we might have lost Dr. Coates, so we will let her come on towards the end of the introductions. Dr. Caslow, would you like to go next?
Yeah. So thank you all for having me. I'm Jacob Caslow here at Vanderbilt in Nashville. Currently, right now, at least in the hospital, we are using Trilogy Evos. Our purchase order for that was approved several months before Philips decided to pull out of the United States market. And that shipment arrived about a day after their public announcement. So we have a new shipment of those that we are using inpatient as sort of a transition vent. In the outpatient setting, while we still have a lot of our kids still on those Trilogy Evos, we are currently in the process of all new patients and then any others that may have any Trilogy Evo issues transitioning to the Ventec, the V-Home, and the Brios 45. We chose those for a couple reasons. One, we have some experience with the Voxin, using that in our neuromuscular kids. So the kids who needed cough assist and 24/7 ventilation, because you can't use any of the other functions without the ventilation portion of that vent turned on. And then the Brios, for the portability, it has the heater is included in the actual ventilator. So for a portability standpoint, if they can't tolerate like an HME and they need that in the volume of air that's actually being delivered. I will say the two caveats to this is that I think the data downloads for these two ventilators may not be as robust as what we used to see with the Trilogy. It's not nearly as granular, and so it's very difficult to utilize the same processes that we've been using with the Trilogies. But I've talked to both those companies, and they do say that there's a lot of updates in terms of the software. So my hope is that a lot of those issues get solved. And so I'll happy to answer questions after everyone does their intros. Again, thanks for having me.
Great. Thank you so much, Dr. Caslow. Dr. Kravitz.
Good afternoon, everyone. My name is Rich Kravitz. I'm a pediatric lung specialist and sleep specialist here up at the University of Virginia. So I kind of use these machines mix and match for different indications, different problems. I kind of work with the philosophy of pump's a pump, and then is trying to find the ideal pump that I can get to my patients in a timely manner. So when I'm seeing kids, I'm usually seeing in one of three fields, either trach vent kids in like our complex care clinic, non-invasive ventilation for our neuromuscular patients, and then traditional CPAP or BiPAP for patients I follow in my sleep clinic. At UVA, we are an Astral program. We have them on the inpatient, we have them on the outpatient. And for essentially the DMEs that cover Virginia, Astral is my only choice. We just recently had a DME company come through as one of our larger providers, and they are starting to introduce the Vivo 45. I have a fair number of patients on the Trilogy or Trilogy Evo, but we're gradually transitioning. Jane had commented about the LTV. I've been around long enough that I remember when all my patients on LTVs had to be transitioned to Trilogies. So this is sort of like same song, different cover as we transition our patients over. I also use standard CPAP and BiPAP for my sleep children. For my younger sleep kids, I have to use a ventilator, so I'm using the Astral for those patients. I've been picking up a lot of Prader-Willi patients as of late, and they are young enough and small enough that CPAP or BiPAP are not approved, so I'm using ventilators for them. In my practice, I used to, for our older kids who just needed a positive airway support, might start them on BiPAP or BiPAP ST, and as their neuromuscular weaknesses got worse, transition them to ventilators, because it used to be a lot harder to get a ventilator. I'm jumping to ventilators a lot more frequently now, and a lot of the home care companies prefer that way. So I'm fine with that. Again, as I said earlier, a pump's a pump. As for airway clearance, we're still using the Respironics T70, but we are in the process of slowly but certainly moving over to the byways. I don't personally have any experience with the cough system. I've had a couple of patients on it, but I need to get up to speed on that. So mostly for me, Astrals and Vivo 45s look like the way I'll be doing things as an outpatient, and the byways will be my airway clearance machine of choice. I am a little tied, my hands are a little tied based on what my home care companies will provide, but they've been pretty good at working with us and helping our families out, especially families that move from other areas of the country. So this is an ongoing evolution, and we work together with the families, us and our home care companies, to give our patients what they need.
Thank you, Dr. Kravis, and I think we can all especially relate to those last few comments. Dr. Kupfer.
Hi, everyone. Looks like my video is not working. Do you guys hear me okay?
We sure can.
All right, I'll figure out my video maybe sometime during this event. So I'm a pediatric pulmonologist in Colorado at Children's Hospital Colorado and the University of Colorado. I think about home ventilation and respiratory equipment in two settings. One is in the hospital as children are getting ready to go home or being put on home-like devices. And we are a Trilogy institution, so we are having to make some shifts. We haven't decided yet which type of ventilator we're going to use, but we have 202s and EV300s. So at least with the EV300s, we are in decent shape for the time being. We also have a small fleet of Voxen ventilators in the hospital, which we've used to really nice effect, especially in our spinal cord injury and neuromuscular patients. In terms of home, as Dr. Kravitz said, many of our device choices are dictated by the DME companies. A couple of our DME companies here in the Denver metro area have diversified their portfolio since the Philips departure. And so currently we're able to get just about any of the three remaining devices, either vHome, Astral, or the Vivo 45 LS. And so I have a conversation with our patients about what they value. Is it more battery life, in which case you should probably go with the Astral, or is it size, in which case you should go with the Vivo or the Astral? So we have those conversations. I have had success with the Vivo in terms of sending complex patients home on high flow and non-invasive ventilation. So the Vivo 45 LS, the vHome, and the Luisa, which we hope is approved for children soon, all have high flow capabilities and multiple prescriptions. So there is also that unique feature. Dr. Keslow also mentioned that the heater The humidifier is integrated into the Vivo 45, but we have to remember that's only for non-invasive use, not for invasive use. But that is a nice feature. And then finally, I brought up to the group the Viair devices, the LTV2 series. I've only ever seen that on their website, and their website also describes that the company was recently sold to Zoll. So I don't know what's going to happen there, but I thought we should include a discussion of that because the LTV1 series was such a workhorse, and it seems like a 2 series is coming. In terms of airway clearance devices, we've used a lot of Byways and Hillrom Sinclair devices. And again, that's more of a discussion with the family. Hillrom, as you probably know, is direct to patient. And so that makes the DME conversation a little bit easier, but they can't service everywhere. And our hospital currently has the Philips T70 devices, but we will be making a move to one or the other of the other devices as time progresses. I think that's all I've got.
Dr. Kupfer, thank you. And I appreciate the comment about, inquiring families what they value as well and incorporating that when we can. So thank you for that. Dr. Mazumdar.
Hi, I'm Hiren Mazumdar. Thank you for having me here. I'm a pediatric pulmonologist and sleep doc. I manage the treatment patients with Tiffany Turner and Jane Taylor here. In our hospital currently, we just have the EV300 in-house. And then at home, we have the Trilogy 200s and the Trilogy Evos. We have not yet really moved to other ventilators, though I believe Jane has some on the Watson. We are part of a much larger health system, and so we cover a large part of Western and Central Pennsylvania and some parts of West Virginia and Maryland. So our choices are made in concert with the adult providers in this system. And the DME companies generally will work with us since we are a larger organization because we're working together. Currently, we are, after we had the experience with Philips Respironics, where we were suddenly left with no ventilator if they stopped making ventilators, we decided that we would go with at least 2 ventilators across the enterprise, so that if one manufacturer stops producing, then we will have another manufacturer. We're not left completely, left high and dry. Currently, we have agreed on the Astral, and we haven't yet got them, but our enterprise has agreed to get the Astral based on positive feedback from other centers, primarily because it's low in weight. It has a good battery capacity. It has a fairly low tidal volume capacity. And also the AirView system to get ventilator data has already been incorporated with our electronic health records. So it's fairly easy for us to get that information. We also use ventilators for patients that are less than 30 kilos to provide non-invasive ventilation and CPAP. And because AirView provides apnea-hypopnea data and leak data as opposed to what ResMed would provide, as opposed to what Philips Respironics would provide, that's another thing that is in its favor. As far as the other ventilator is concerned, we haven't yet decided which one. We're still waiting for things like the Louisa to get its FDA approval for pediatric use. Our adult providers have used the Louisa, and they seem to have fairly good feedback about it. However, my understanding is that their integration with electronic health records is not optimal, and perhaps is something that we would have to look at carefully. And I think I like the fact that we'll have a limited number of ventilators because it's much easier for our respiratory therapists to be very familiar with them, both in hospital and outside the hospital. Our inpatient respiratory therapist works closely with our outpatient respiratory therapists, and so that gives us good continuity. I think one of the things that we're going to look at as we transfer them from the Trilogy Evo to the other ventilator settings is to make sure that their ventilator settings are appropriate for the new ventilator, because every manufacturer decides that it wants to have its own branded name, and so it's quite a bit of work to make sure that they are getting the same vent settings when you move from one to the other. And so our respiratory therapists will be helping us make those calls and error checking and making sure that the settings we send to the DME company are appropriate and that the DME company actually puts in the appropriate settings. So that I think will be something that's very important for us to do across our patient population. As far as the cough assist machines are concerned, as Jane was saying, we use all three and they've all worked quite well for us. I don't have any particular preference across the three. I will say that a lot of it depends on what's available in the market. And so that has really driven a lot of what we supply our patients. And that's all I have to say for now. And I'm happy to move on to the next person.
Thank you, Dr. Mazumdar, and particularly interested to hear about that collaboration that you have with your adult colleagues, as well as the communication between your inpatient and outpatient RTs. And so that's a natural segue into our next speaker, Michelle Wright. And I think we may be having some technology challenges for Michelle. Michelle, can you hear us okay? If not, we can pass on Michelle for now, and that would bring us to Brian Yoho.
I think Brian may not be available today.
Hey, Dr. Mazumdar, I'm actually on the meeting, sorry.
Oh. All right, go ahead.
And Brian, if you want to introduce yourself, you can give people kind of the insight on someone who was one of our inpatient RTs who now is helping us on the outpatient side as well.
Yeah, so I've been an RT at Children's for 20 years. The first 13 years of my career, I worked in the critical care area. Dealing with some of the home care kids, obviously, and then the last 7 years of my career, I've been on the outpatient side. More specifically, the last probably 3 years, I've been working with Dr. Taylor, Dr. Mazumdar, with the home ventilator program, trying to standardize our care there.
That's excellent. And for those of us, on this call, is there any particular advice that you've had in the various experiences or in what you would share from your inpatient experience with outpatient providers in helping with transition from inpatient to outpatient care?
I guess I wouldn't say anything specific. We work pretty closely, inpatient, outpatient. So I would say, getting a patient ready to go home from inpatient to outpatient is pretty seamless, whether they're leaving from our hospital or whether they're leaving from one of our rehab unit or one of our units outside of the hospital. We're still pretty closely involved with those patients. So we know what ventilator settings they're on. We know where they're at, where they're headed, where Are they ready to wean? Are they ready to go home without their ventilator?
So I can add a little bit to that. So Michelle, who seems to have difficulty with communicating, does a lot of our transition work. So we work with our patients before they go home. Our outpatient respiratory therapist, Michelle, works with our patients for several weeks to months before they go home and puts in place a standardized plan of care with our inpatient respiratory therapist who's dedicated to our home ventilator service. And so when they come in, we already have their settings and we have a plan of care. But most importantly, the family is comfortable with who the personnel that are going to take care of them and know whom to reach if they have issues, or if we reach out to them, that is already in place. And we have a documentation system in Cerner that we have implemented that is specific to the outpatient system. That's already input before the patient goes home. And we set up a care action plan for them in the health record that is available for the patient when they go home. And when they call in, that information is already available. So, and then once they come into our outpatient clinic, Michelle frequently interfaces with our inpatient respiratory therapist for troubleshooting. Given that she has a very vast knowledge base of experience, I think it's been a very fruitful interaction for us. That's what I have to say for that part.
That sounds like such a model for us all to aspire to. Certainly practicing in Northern New England, I feel that communication between the inpatient teams and the outpatient teams can be especially challenging, and errors or miscommunications about various settings, particularly if there's a change in a type of event, can be fraught with error. So it certainly sounds like the model that you guys have at CPMC is really ideal. Were there any other comments that any of the other panelists wanted to make at this time before we move on to the questions in the chat?
I just wanted to say, this is, as I think Dr. Kravitz says, I want to encourage like more people asking questions, because this is a time of transition, which we are seeing for different ventilators. But I think Dr. Mazumdar that brought up a very important question that I want to lay, that we really feel is that how do we change these ventilators from from Trilogy 200 to a Trilogy, EV 300 even, they have changed the way those pressures, the PEEP compensation of their mode, how the EPAP is different. So I think that everybody has to be very, very cognizant of the settings, how they change, even if the same ventilator in the same type of companies, they have changed the way the settings are set at to meet the same, to be equal in settings. And I'm glad that so that's where it's important for the EMRs to have the right order system, just not based on the total PIPs or so the respiratory therapist actually understand what the orders are. And the second thing is all the, as we are getting towards technology and AI and towards the downloads, and having that included in the EMR is unique, which would be great to be able to see that. And there are now in vPro, we found that there's a data link system, or there is a way that it will be connected instead of being a download. It can be connected the way it is through the bi-level vents, like your data would be automatically sent to the satellite and back to the system. So it is not dependent upon the respiratory therapist going and downloading the vent. Or like Care Orchestrator and other things that they also had in Trilogy, but they had a system like you have to get a web-based, like a modem or something. But now they have it attached, and the cost is, I think, what they told us is $8 per month. So that could be very easily be bearable by the DME company. So I think there's very, very small nuances to be very careful, to be very careful, and that can help us to make it more effective, the use of ventilation and management of ventilation in outpatient and patient settings.
Great. Thank you, Dr. Agarwal. And to you or any of our other panelists along those lines of nuances between the various ventilators, are there any particular resources that you recommend in addition to this town hall, for example, or Dr. Taylor's phenomenal grand rounds that she did for those who would want to understand those nuances more? Any particular resources you'd recommend?
So rather than resources, I would recommend that we have an error correction system in place. And I think it's really important that you have someone, in our case, it's going to be our respiratory therapist, who checks the changes and checks with the Excel spreadsheet that tells us that one ventilator has a certain setting and the other has another. And then actually checking with the DME company. Actually, just today before this town hall started, I had a patient in clinic who had the appropriate vent settings sent to the DME company. But on moving a patient from a Trilogy 200 to a Trilogy Evo, and the DME company had still made an error. And I think error checking is really something that's really critical for our patients. I think in this instance, it didn't matter, but there could be instances where it is significantly concerning. And I think more than a resource, having that's one of the reasons why I think having a limited set of ventilators with a fixed number of corrections that we need to assess is really helpful in implementing, relatively error-free healthcare.
Well, if I may just add to that, I think the bottom line for all of us, and I'm preaching to the choir here, is patient safety comes first. So there's many DME companies that would like to go out to the patient's home, switch the ventilator, plug in their same settings, and take the original ventilator back with them. And that's totally unacceptable. If these patients are going to be switched from a Trilogy to an Astral or a Vivo or whatever, it has to be done under supervision. That can be in the clinic, it can be in the hospital, depending on what works best for the family and the staff. But we don't do any transitions until my RT has met with the family and the company's RT to make sure everything's in line. And then even then, we'll send them home on your new ventilator, but keep the old ventilator in the house for at least a couple of weeks, or at least the viral illness, to make sure that the settings do really sync up with each other.
Thank you, Dr. Mazumdar and Dr. Kravitz. Any other comments from the panelists before we move on to the questions in the chat?
Yes, last comment would be also be cognizant that the newer ventilators are very sensitive, and they have triggers, so like even if we go from Trilogy 100, 200 to Evo, and they have very sensitive triggers to be 0.5, and that makes it very sensitive. So be understanding how you can help in synchronizing the ventilation with the child, because it does help. But if we do it too sensitive, it may cause auto triggering and other things to be just sensitive, because there are a lot of bells and whistles in the newer ventilators, and so to be very cognizant. And other thing is, I would also say the circuits are very important. What you use the circuits, like if we are going on Astral, the more it becomes complicated using dual limb circuit, how easy is to manage at home with the DME companies, because sometimes the hospitals, respiratory therapists and everybody is very good at the system, but how good it is in the outpatient world, that's also very important to consider while choosing what ventilator devices, if we have the choice. So, but I'll want to make sure that people ask questions rather than we speak. So sorry.
No, that's great. Thank you so much. Dr. Gallardo, do you want to start with the first question in the chat?
Sure. I'll kick it off with a comment and a question from Dr. Janice Richmond Eisenstadt. She comments that Respironics Cough Assist MIE machine has not been available for sale in Canada since June of 2022. And she has a question. My neuropulmonary patients who are adults tell me that they don't feel as much oomph from the Sinclaira as with the Respironics Cough Assist machine, especially from the oscillation settings. Any advice? Is there a way to adjust settings for greater effect and improved insufflation volume and higher peak cough flow? So I'll open it up to the panelists.
So I can try to answer that question. I've heard similar things where each MIE device feels a little bit different to patients. And what I end up doing is just clinically titrating them to effect. There's some data out there that suggests that inspiratory pressures above about 30 don't really change the peak cough flow, and adjusting the expiratory pressure may do more good. There's no reason to have symmetric inspiratory and expiratory pressures or times either. It's convenient for us to do that, but you really don't have to do it. Some will advocate for a stronger expiratory pressure than inspiratory pressure to augment bias flow. Or to augment, cephalad flow of mucus. And others will say that that might cause airway collapse. So I think it really has to be a clinical titration. Beyond that, I don't know that there's any science to it.
Thanks for that, Dr. Cooper. Do any of the other panelists have any input on that question?
The only question, I have not experienced that, and I don't have experience with the Sinclair cough system, so I can't really comment. My question is, do you think that it could be instead of a pressure, not enough oomph, it's the flow rate at which the pressure is delivered? That's the subjective experience they're having?
I think it's a rhetorical question, but Richard, but yes, it certainly could be. So I like to ask Goldilocks questions for ventilators, and I think it works with cough assist as well. Are you getting a big enough breath, too small breath, or sorry, too small, too big, just right? Is the flow too fast, too slow, just right? Those kind of questions can really help titrate if your patient is willing to participate in that game. And then I thought there was another question.
Yes.
Yeah.
Oh, sorry, go ahead.
There's a higher PCF when oscillation is off exsufflation cycle.
I think others can jump in here too. I'm by no means the only expert on the call. I have not seen a tremendous benefit in peak cough flows with oscillation. I've intermittently played with only doing it on inhalation because I don't want airway collapse as we exhale. But I don't know that there's much data to suggest that it does a whole heck of a lot, honestly. There's one paper that suggests that it doesn't. Some of my patients though do report that they feel more comfortable and that it does move mucus better to have oscillations. I think that's probably a patient-specific factor.
Great, thank you. And in follow-up, Dr. Kravitz commented that he hasn't noticed any difference, but never really looked that hard. I had a question because this is an experience. One of my colleagues who's also on this, the town hall, Dr. St. Ange here in Maine. We've had some in challenge more and more challenges with having hospitalizations approve when a ventilator has been changed to observe stability and how a patient is tolerating that, and or tolerating further hospitalization time once the ventilator is delivered from the DME to have ongoing monitoring in the hospital. Has anyone else experienced that? And if so, how have they been able to troubleshoot that?
We actually don't get the home delivery till we are comfortable with the hospital stability. And I think it's precisely for that is you don't get both. I know I'm interested in hearing how other people are able to get a home ventilator and have the patient stay in the hospital.
Our DME companies give us a brief amount of time in the hospital with the devices. So for patients who are starting on a ventilator, like the babies coming out of the NICU, they give us a decent amount of grace period, but that is decreasing. For patients in whom we're transitioning from one ventilator to another, I think we make a very strong argument that this is life support and that modifications are not necessarily safe to do. And furthermore, especially for pediatrics, the parents have to learn how to use the ventilator, and that requires some time spent in a safe setting. So we use the safety argument, and I don't know that we've had issues with it, but I also know that at least in the US, each state and their Medicaid decisions seem to be random.
Yeah, I mean, I can say about Arkansas is the same. We have like a policy that a new ventilator, the patient has to be, if he's going for first time home, has to be on the home machine for at least 48 hours or 48 hours to make sure that home machine is like we have set up everything right and it's working and the parents are familiar with it. So that has not been a problem from the DME companies wise, because I think it's more of the DME companies who actually wants to also have that availability. And especially like if you see some of these ventilators do not have like V-Home Trilogy home, like Evo is slightly different with EV300s in some of the cases. And so especially like definitely how the oxygen is connected, so it helps the parents to be taught. But I think one of the factors that is important is as we are transitioning to a different devices, transitioning from ventilator to another, I found that many places are using, especially when they were transitioning from Trilogy 200 to Trilogy Evo, that they were using outpatient, like 3-4 hours in the outpatient, and to help that instead of admitting everybody. But if they are using a totally different ventilator, I think we have been successful because of the same argument of the safety, because these are life, life depends on them, and there needs to be an time of like learning curve of understanding the different things on the ventilator and different alarms on the ventilators. So that's what we use. So it'd be interesting to see what other people have.
So we have an interesting system here where as we're preparing the patient to go home from the hospital, we send them to another facility down the road that's not part of our hospital system that charges patients on a per day pay basis, charges the insurance plan. And I don't quite know how the insurance part works there, but they work with the insurance plan and give the diagnosis. They get a certain number of days that the insurance plan pays on a per day basis. And presumably it's much lower than what they would pay the hospital. I would have thought that would be a great way for us to transition ventilators. Unfortunately, they're pretty packed in their ability to accept patients. And so that's not something that works for us. But traditionally, once we deem that a patient is steady on a ventilator before we send them home, while the parents get trained and they get nursing support and their DME infrastructure at home is assessed, we send, I would say 80% of our patients to this transitional facility. And I'm wondering if any other hospitals have a similar plan of transition.
We don't have in Arkansas that luxury of long-term care facility. So
it's not a long-term care facility, it's an acute hospital. It's by the state certified as an acute hospital, and it essentially does a lot of chronic care. So like if a patient needs to go home on gastrostomy feeds or they need to go home on TPN, then they'll prepare them once they're medically stabilized. Then they'll prepare them while they'll hold them while the nursing and other infrastructure and training is done. So that's an interesting setup, which our hospital system does not seem interested in taking over. Presumably, the revenue structure is not something that is to their choice, but it seems to be a unique facility that we have here. It has its pros and cons.
Yeah, I mean, sometimes there may be social reason that the patient may stay there because of they cannot like that's one of the very important aspect of all the hospitalization is that there may be like single parent, or they cannot get trained in time, and so there is a lot of length of stay that is there. So I think it is very interesting that acute facility is able to take that, and it talks with the insurance for the amount of time, because it's a time bound thing. If the parent does not get trained in maybe 2 weeks, 3 weeks, 4 weeks, then who eats the cost of it?
Right. So it's generally the hospital system that eats it up, right?
Yeah, generally in our system, it's the hospital system or the Medicaid or whatever. But I do not know how that system, because that's a very unique model that we don't have it here.
There seem to be a bunch of questions that have come up.
Yeah.
Yeah, and since we're nearly at the top of the hour, I think that Dr. Gallardo was just going to read one more question, and then we'll turn it over to Dr. O'Hagan to wrap up this excellent town hall. I'm so thrilled with all the interest it's generated.
Sounds great. So I'll take our last question from Dr. Richmond Eisenstadt. She said, we titrate all of our MIE setups home, clinic, and long-term care. Is there a difference in set pressures between machines? In other words, is -40 on Respironics MIE machine not the same as -40 on the Sinclaira? If any of our panelists want to chime in on that question.
It should be the same at the end of the day. You just want to make sure that the flow rates are the same and the inspiratory pause and expiratory times are the same, but they should be the same.
Thank you for that.
Yeah, and this is Jane Taylor, just to add that, yes, they're supposed to be the same, but I do have some patients that feel on the Sinclair they need to have a 1 or 2 pressure difference higher when we've transitioned. But if you read the insert, supposedly it's the same.
All right, well, thank you, everyone. I think this concludes the pediatric town hall on the evolving landscape of the home respiratory equipment. These initiatives could not occur without the strong support of the American Thoracic Society and the Pediatric Assembly in particular. I wanted to thank Dr. Jane Taylor for her conception and planning of this town hall, the moderators for keeping us all on task, the panelists for their time, knowledge, and opinions regarding the topic. And finally, I want to thank all of you, the participants, for making the time to join us today. For any of your colleagues that couldn't be here today, please let them know this recording will be housed on the Pediatric Assembly page over the next few weeks. For those that haven't had the opportunity to visit the site recently, it is a great repository of town halls, webinars, journal clubs, podcasts, quick hits, and the pulmonary sleep case series for your viewing pleasure. I put the link in the chat if you need it. And then please reach out to any of the organizers with topics that you'd like to see covered in the ATS Pediatric Assembly as it continues to promote the respiratory health of children through research, education, patient care, and advocacy. And with that, we want to wish you all a safe and happy holiday season.
Thank you.
Thanks, everyone.
Thank you, everyone.
Thank you so much. Great job.